Okay, sure. Okay, we're going to cover the topic of advanced colorectal cancer with an emphasis on beyond second line. So this is the frequency of people that, patients who arrive with the treatment after the first line, second line, and arriving third line. It used to be in the range of 10–20%, but nowadays it is certainly more than 50%. Now, and the goals of the treatment is certainly different. We have, so I'm going to cover, first of all, the endpoints that we can pursue once we reach a third line and beyond. Which is important because, of course, there are exceptions. Then I will cover the 4 options that we have at our disposal for addressing the issue of how treating a patient in third and fourth line, with the 4 major actors being reintroduction or rechallenge, regorafenib, trifluridine, and the other actors belonging to the world of precision medicine. And I will close with the sequencing between the 2 players that have established their role through randomized phase 3 studies, that is regorafenib and trifluridine, when to prefer one and when to prefer the other. Finally, I will have 6–8 slides on clinical conditions. So these are not cases. The reason for going for a clinical condition for discussion is that when you present cases, most of the most important aspect of our decision-making process is how the patient feels, what his medical conditions are, the mental attitude, and so on. So most of the times you end up saying, well, I did that because of these patients' characteristics. So what we are going to do here is leaving aside the patient characteristics and just concentrate on the disease and the clinical course of the disease, so that we can address the best choice that can certainly be modified according to the other determinants. So, endpoints for second lines. This slide is very important because it puts into perspective the hierarchy, most important to least important endpoint in our clinical practice. Of course, cure ranks on top of the list. Then we have overall survival, and in the adjuvant setting or the radical setting of stage 4, relapse-free survival, whenever we can reach complete response, and quality of life, as well as symptom palliation. There is a space here because these are patient-related endpoints. Therefore, they rank above the tumor-related endpoints that are PFS with responses, partial responses, stable disease, and so on. So these endpoints apply to all of these endpoints, apply to the adjuvant setting, the first-line setting, and sometimes the second-line setting, because it is not unusual that you have a patient who has never considered to be resectable in terms of his metastasis, that initially responds to first line, then goes to long time maintenance, and then maybe for a small progression, you start a second line and he responds again. And now at this point, 2 years have gone by. And at this point, the 3–4 lesions in the liver that initially constituted a contraindication for resection, after a clinical course of 2 years with few changes, and now the issue of resectability comes back into place. So essentially, cure and rendering the patient disease-free are the main endpoints of a first and second line, and of course the adjuvant setting. But when we speak of third line and beyond, actually we are recognizing cases where cure is certainly not possible. And also the possibility to eliminate completely the disease should not be possible. Otherwise, we have made some mistake in the prior lines. Okay, so all the goals remains in extending survival, improving quality of life, symptom palliation, and of course, tumor control. Now, as I anticipated, we have 4 different actors. Let me go back to the 4 actors. These: reintroduction, challenge, regorafenib, trifluridine, and other. I will stay away from the precision medicine type of approaches because they are not relevant to what I just said. Okay, that is a classical third line. We have at least 5 avenues to pursue in different lines with what we call precision medicine. Of course, the most important of all, the revolutionary change has been for the MSI tumors, the use of checkpoint inhibitors that constitute a real revolution because you can cure them. So somehow it is relevant in beyond second line as well, because whereas in America, these drugs have been used since 5 years ago, and now it's very difficult that the MSI patient is not treated with checkpoint inhibitors in first line, and in Italy is becoming the same. Sometimes, though, we can still see patients where the MSI, MSS status have not been investigated yet, and they are in response after first line. So you don't change the treatment. So you reserve the checkpoint inhibitors for second line, and some other time you see patients in second line that are not progressing, say under, say, FOLFIRI, BEV, or whatever, and you realize that MSI, MSS has not been tested yet. Okay, so that is really the game changer, MSI, MSS. But we have other avenues that can be pursued even in third line. For example, for the BRAF mutated, of course, encorafenib and cetuximab is the way of going. For the HER2 amplified, the anti-HER2 host of compounds can also be pursued. Number 4, for the RAS mutated, the G13D, G12C mutation, we have both sotorasib and adagrasib with, in combination with the anti-EGFR compounds. And finally, we have the possibility of the rare cases of the NTRK fused patients where we have specific inhibitors. These are the 5 avenues. On top of these, we can also recognize a 6th avenue to pursue on top of the 3 that I described here, and that is the experimental arena for the MSS patients with combination of checkpoint inhibitors plus other immunostimulants, such as, say, still in the experimental arena, the anti-LAG-3 plus pembrolizumab, for example, or nivolumab. Okay, getting rid of these 6 avenues, let's go back to what we have at our disposal in the case of a true third line. And as I said, the first possibility is reusing something that we have already used. Now, there are 2 ways of reusing what have already been used. And the first way is when a patients have been treated, say, with Xelox Bev, and then, as you know from the Mayo Clinic study, Xelox must not be continued indefinitely, because the trial from Mayo Clinic demonstrated an advantage in overall survival if after 4 or 5 months you stop oxaliplatin, you continue with the fluoropyrimidine plus Bev, and then upon regrowth of the tumor, you reinstitute oxaliplatin. But say at that point, you could also change and go to FOLFIRI. So maybe 6 months down the line after this change, now you can consider this condition in third line, because the patient had a first line that the patient never failed. But you started a second line, FOLFIRI Bev. Now that is the case of so-called reintroduction. Actually, this case is not a third line. This is a returning to first line. And the results are shown, say, in one of the several small size phase 2 trials of reintroduction for oxaliplatin, showing a 50% chance of reducing the tumor burden here. Now, this is a reintroduction that, again, is not third line. Again, okay. Different is the case of the patient who received Xelox Bev, say, and then stopped oxali after 4 months. And when the disease regrew again, you reintroduce oxaliplatin, and then the patient fails. Then you start a true second line, say FOLFIRI. And when FOLFIRI fails, then you're facing the classical and typical condition of third line. Now, under those conditions, how about returning to the first line? And that is the real re-challenge. Re-challenge with oxaliplatin shows this type of efficacy on 30 patients, say again, 6% partial response, and about a third of control at 2 months, which is certainly not, first of all, these data come from non-randomized trials, and second, certainly they are not so brilliant. But this is a true re-challenge. The same is true with the anti-EGFR compounds. And say, the idea was really appealing that the sensitivity to anti-EGFR may be lost because of the overgrowth of RAS mutated clones. But with time, these clones may be overgrown by clones that were RAS wild type. So the idea of reintroducing or re-challenging was fairly good. And there have been 2 trials on a fairly large amount of patients showing these type of response rates. I looked into this data quite closely, and I spoke to both PIs of these studies and found that none of these patients were really a re-challenge. So these were reintroduction. And this is actually what we would expect, that the patient never failed the anti-EGFR in the first line. And of course, if you intersperse a second line in between, but the patient never failed it, when you reuse it, you'd expect a high percentage of responses because you have selected those patients who responded. Okay. Instead, when you look at the patients who failed the anti-EGFR in the same way as I presented with oxaliplatin, then we can speak of true re-challenge. And there, the figures of responses are much smaller than those accounted for by reintroduction. Still, I have to caution you that these are not the real figures if you start from the overall population. let's look into the details of these studies, starting with the cricket study that is fairly well known, because again, when we speak of third line opportunities for colorectal cancer, that's a common condition that we have. So having the possibility to use other agents on top of those that have been shown through phase 3 randomized studies like trifluridine or regorafenib, having something else is always very appealing, because we know that rego and trifluridine are not so efficacious. Okay, that's a problem. So this is why these studies on re-challenge with anti-EGFR being pushed a lot by drug companies, okay, have gained popularity. But the point I'm going to make is that while you see that confirmed responders are 4 out of the 13 with wild type circulating DNA, the denominators where this 4 responders were obtained is not 13, but is 28 patients. And out of 28 patients, 3 had non-evaluable circulating DNA. So those must be counted whenever you start thinking of re-challenge with anti-EGFR. And the other 12 continue to have mutant clones of circulating DNA, of RAS mutated circulating DNA. So actually, the response rate when you try to use a re-challenge strategy with anti-EGFR is 4 out of 28, which is 14–15%. And the same is true with the Kronos trial. Again, a very nice trial that is, again, has met a lot of popularity because it's a precision medicine type of approach. Still, the same was true for this trial. 8 out of 27 patients where liquid biopsy gave positive results obtained the response, accounting for a 30% response rate. But how many of those patients where the re-challenge strategy was attempted were screened? Well, the answer is 54. So this percentage should be cut in half, 15%, starting from non-selected patients. Okay. The other 2 possibilities that we have are to use regorafenib or trifluridine tipiracil. And this is, and these are the 2 treatments that have been approved based on randomized comparisons. So essentially, those are the 2 standard of care. Let's look at the results with a lot of, say, critical view. Let's criticize those survival curves and the other data. This is the correct. I have been the top accruing center in the world in the correct trial, and we have accrued 25 patients also in the Concur trial, that is the trifluridine. So I have experience with both. Let's analyze critically this curve. This is a banana-shaped curve, a Kaplan-Meier curve, meaning that it starts together and then the 2 curves go back together. And the first thing I'm used to look at these curves is how about long-term results? So I concentrate on the scale down here. And the scale I see that goes until 1 year, unfortunately. And the percentages here are down to 25% at 1 year, and the 2 curves collapse, go together. Then the next way of looking at this is the classical way, and that is, what's the hazard ratio? The integration between the 2 curves. Hazard ratio here is 0.77. 0.77 is still below 0.8. 0.8 is really not so appealing in general. It may be appealing when you have a median survival, say, of 4 or 5 years. like in the latest trial in breast cancer, okay, a 20% increment in the median, say a 20% increment overall, may translate into 20% prolonged median. So if you have 4 years of median, you extend this with a hazard ratio of 0.8, you extend that by 1 year. That is a lot. But when our median is only 5 months, 20% more of 5 months is 1 month. Boy, quite irrelevant. And indeed, in this case, the median is the place where the difference between the two curves is maximum. You see? Because if you count here, the difference is minimal. Here is 0. So by giving just a median, we are giving the widest difference between treatments, and one treatment is placebo. What else? Well, the other way to look at this is looking at the late effects. And I want to see late in the language of a patient is 5-10 years. Then I may convert him in thinking closer. But late is usually at least 1 year, 1.5 years. You cannot look at the 6 months, 8 months. That's not so late. And at 12 months, there is no difference. Still, I was so enthusiastic when these data came out. I was very enthusiastic, essentially because I had nothing. The alternative was 5 months, and now this was 6.4. And the alternative was not having anybody, not so many patients alive at 8 to 10 months. And here we raised a bit. So I celebrated this. I was happy because I had something more to offer our patient, not that much. Now let's look at the data on trifluridine. The first thing we looked at in the previous curve was the 12 months mark. And here, the 12 months mark is not a banana. You see, there is a difference. That's not bad. That's better. Let's look at the other parameters. The median. The median, 5.2 months to 7.2. Oh, come on. That's not so different from the previous median. The previous median was 5 to 6.4, is 1.4 months. And now we are discussing about 2 months. Well, I cannot feel like saying that that is a huge difference, right? I hope you agree with this. Still, if you look at the whole curve, I note that the hazard ratio is below 0.7. Now, this is important because this means more than 30% increment at any time, right? As opposed to the 0.77 hazard ratio with the correct. But again, how often do you explain these data in terms of hazard ratio with your patients? Never, never, ever. So again, the strong point here is that at 1 year, I have more than 10% additional patients alive, 16.6 in the control, and now 27%. So in relative term, this is an additional 10%, which is more than 50% of the 16% of the control, meaning that this segment, do you see the arrow? Do you see my arrow? Make a sign. Okay, thanks, thanks. You see this segment is more than half this segment. So we could say that the absolute gain at 12 months is you have 11% more chances of being alive. That's one. The second way of presenting this is that you have 60% more chances of being alive if you don't do any, as compared to doing nothing. Okay? And these are the two ways of presenting these data. And these data are presented here. I know that this is torturing data, but you can torture the data for the correct, and you will not end up with these results. Because as long as you torture these data, you will find 0% improvement at 12 months. And you have a 25% improvement at 9 months. Here you have 66, which is reflected in the difference between 0.69 hazard ratio and 0.77. And the median being 40% additional 2 months out of 5 months, or 30%, that is 1.4 months out of 5. Okay. Now, whenever you have your patient in front of you, he is never the average. He may have positive features of the disease, a nice clinical course, few liver metastasis, a performance status of 90%. Okay, if he's in that very nice condition, these are the differences that you may observe. Instead of having 8.6 months in median survival with no treatment, you extend his life by 8 months in the favorable group. Now, this is very important for choosing what to use under different conditions. And remember this number. Now, again, this may not be the efficacy of the drug, maybe the condition, of course, because I'm selecting patients. So scientifically, this is not strong, the data. But from a clinical perspective, the clinical practice viewpoint, this is terribly important because the patient with those characteristics will have these benefits. Okay. On top of all this, in the study on trifluridine, we had the same advantages, actually more pronounced, in terms of a sort of surrogate of quality of life. That is the time to deterioration of ECOG-PS becoming more than 2. Now, this is not quality of life, of course, but the shape of the curve reflected that of survival, meaning that the survival that you gain is of good quality. The same data have been duplicated in the pre-connect phase 3B, that is a single arm, sort of real-world type of evidence. Now, so let's see what are the convincing part and the more challenging part of these data. If I tell my patient that through these treatments, you gain an average of 2 months, well, I don't think that is so convincing. And of course, it's even less convincing if I use the 1.4 months that the correct study provided. If I tell the patient, well, the hazard ratio was 0.69, that means a 31% improvement in overall survival. Again, I have trouble myself understanding the hazard ratio. I remind you that the hazard ratio is the ratio between 2 speeds of events. Let's leave that away, okay? Because that's extremely complicated. So I find it challenging. What I find convincing is that I can tell my patient that if I give him this new treatment, he will have 50% more chances of being alive at 12 months. Now you can decide whether to tell him that the 12 months survival rate under those conditions is 16% and that he will go up to 27. Okay, but still that is certainly true given from the trial. And of course, I can tell him that the amount of survival gained is of fairly good quality. Okay, what else out of these two studies? Do I have predictors of efficacy? Yes, I do. In the recourse study, if the patient develops even grade 1 chemotherapy-induced neutropenia, the gain in benefit, this is the overall benefit, okay, of those patients not producing any neutropenia, goes up to 9 months, which is reassuring. Also because having a neutropenia doesn't mean impacting on quality of life. Do we have the same data for regorafenib? Yes, we do, luckily. Unfortunately, though, you see the same type of extent of benefit here with this is a survival. Exactly the same. Median becomes up to 9, almost 9 in the treated group. The only problem is that this is the hand-foot-skin reaction. And the hand-foot skin reaction is not like neutropenia, is impacting on quality of life. So for both agents, we do have predictors of efficacy, but one impact on quality of life, the other does not. Okay. So let's go to the conclusion. Let's consider several aspects for the head-to-head comparison that has never taken place. The first is the fact that the rationale of regorafenib may be regarded as stronger. Why? Well, because it's a dirty TKI, so has a novel mechanism of action, whereas trifluridine is a fluoropyrimidine, and we have that since 1956. So it will be, well, careful, because trifluridine doesn't work as FUDR or fluorouracil or the other fluoropyrimidines, because fluorouracil works via inhibiting thymidylase synthase, which means inhibiting DNA synthesis, or, and that's one mechanism of action. The second mechanism of action is being converted into FUTP and being inserted into RNA. Trifluridine enters DNA, so it's not fluorouracil, completely different. So in terms of rationale, maybe you can give a plus to regorafenib because it is a biologic, whereas the other is an anti-metabolite that works as an alkylating agent, essentially. But I think it is a tie between the two. Okay. Possibility of outliers. This is terribly important, because as we have seen, the median duration of life is not that different, to say. Okay. But we have seen that we have outliers that may go beyond 1.5 years. And we can see that for either agent. So I think that's a tie as well. Okay, they tie. There is not a superior one. In terms of overall survival, the hazard ratio is quite drastically different. One is below 0.7, 0.69. In terms of ESMO and ASCO ranking, it gets a higher grade compared to the 0.77. 25% prolonged PFS. That's identical. I didn't show you the curves of PFS. They are absolutely identical for the two agents. 25% do not go into progression up to 4 months, which is not that brilliant, but it's still something in patients where 100% will be in progression at that time point. Tolerability. Here is the big difference, as emphasized before. The limiting toxicity for trifluridine is neutropenia. The limiting toxicity for regorafenib is a hand-foot skin reaction and weakness, asthenia, that type of tolerability. So much more in favor of the TAS, of trifluridine. Toxicity related determinant of efficacy. Again, we do have determinant of efficacy, but one impacts on quality of life, the other doesn't. On quality of life, we do not have studies on quality of life for neither agents. Nevertheless, we have the ECOG-PS, time to deterioration, for the trifluridine, and that gives a plus for trifluridine. So altogether, we can understand why the recourse study on trifluridine was published on the New England Journal of Medicine, whereas the recourse, the correct study on regorafenib made it on the Lancet, which is different, okay, for all these reasons. Okay, so in terms of preference, well, marketing data from the whole world indicates that trifluridine is prescribed in third line by more than 80% of physicians, and regorafenib is preferred by 20% of physicians. These are marketing data. In terms of clinical approach, this is my approach. The patient has suffered from, say, neutropenic fever and sepsis in prior lines. If yes, I would go with regorafenib because I will be afraid of the neutropenic toxicity of trifluridine. If, as it is true for more than 80% of cases, the major problems with toxicity has been symptomatic toxicity and the patient is tired, then 8 times out of 10, I will prefer trifluridine, and then reserve regorafenib as a fourth line of therapy. Now, so the conclusion, and here I end with my presentation and move to the discussion. Oral drugs monotherapy, meaning trifluridine or regorafenib, are the standard of care. Others, for sure, if the patient is MSI. Third line, a case of third line that is MSI, of course, goes to checkpoint inhibitors. Okay. When do I choose a rechallenge and go against the standard then? Because the standards are these 2 drugs, okay? But there are conditions where I go for rechallenge. First condition is actually when it is not a rechallenge, but it is a reintroduction. Why? Because the patient is not in third line. But even in those cases, I needed to have a tolerable toxicity in prior lines. Because if the toxicity was intolerable, then it becomes a third line. And tumor shrinkage is needed. Because if I'm 3 years down the line, and now the toxicity was bad, and the patient is not going to rapid progression, then I may avoid reinstituting a toxic treatment. Or when the condition is a true rechallenge, but then I need 5 conditions to be satisfied. Number 1, that there has been a prior response and not a stable disease. Number 2, that this response was sufficiently long. Number 3, toxicity was tolerable. Number 4, now the progression is rapid and I need tumor shrinkage. And number 5, either liquid biopsy technology is available, then the biopsy should be positive, meaning RAS non-mutated, or if the technology was not available, a very, very long period has gone by, although that has been challenged lately. Okay, now with this background, we move to the discussion. And I'm going to ask you what you would do. First case, This is the tumor mass growing, non-resectable, clearly non-resectable patient, average patient, a 60-year-old. You start the first line, you get an average toxicity, you get a 30% reduction, and after 4 months, you start the maintenance treatment that luckily go ahead for 8 months. Fantastic. Then you get fed up with treatment and you give a patient a pause for Christmas, say, okay. And then after the pause, the patient go into progression. Well, that's natural, normal. In this case, you decided to start with a second line treatment that is actually not a second line, okay, because the patient never failed the first line. Still, it's reasonable to go with, say, FOLFIRI-Bev, and you get some shrinkage, minimal, but you see how favorable this condition is. 2.5 years down the line, the patient is in slight progression, never having failed the first line, and having still available trifluridine, regorafenib, and of course the first line. And the question, what would you do at this point? You want to comment? Again, several choices here.
Mm-hmm. Yes, I can comment on that. Actually, I would like to congratulate you for the presentation. I think that, as you told, I think that the hardest thing in colon cancer is to define which line you are in. So most of the patients, they do chemo and then they do surgery and then they go back, and it's kind of hard to understand if they're in second, third, fourth line of therapy. But in this case, one thing that is challenging, that what you said is that, I mean, if it's a patient that has a slow progressing tumor, and then maybe you don't need as much response. So, I mean, if you're trying to do if your first goal is quality of life, then maybe I don't even know how you speak in English. We call it TAS here. So I think that the drug, this kind of drug would be, a great thing to do at this point. So you can delay chemotherapy.
Thanks for the comment. Andre Sassi?
Yes, I will comment too. I think I love your presentation about how convince the patient to do to use the options we have for them in the third or later lines. So that's because here in Brazil we have some access issues. We don't have coverage from any regorafenib or TAS for this patient. But we have access to endovenous chemotherapy, traditional rechallenge or re-exposure of the same drugs we already did. So sometimes we have some theoretical discussion about the best options, but in fact, we have to discuss with the patient the cost of the treatment, the out-of-pocket necessities of treatments, and the options are made considering the costs for the patients or for the system or for the environment in the patient is in. So it's difficult to choose. Probably in my clinical practice, I will offer the same chemotherapy we use in the first line in this case, just because the access problems. If we have access for all the treatments, we can discuss with the patient the best option. Probably we can offer a TAS because of the quality of life, the expectations of control disease, and the other, again, theoretical things about the strategies available.
Yes, Anna, comment? Do you feel the same?
Yes, I feel the same. At this point, I would like to know about neurotoxicity, to know how to reintroduce the first line. And I would like to make a question for you, Dr. Sobrero, about this case. As we saw, the best prognostic group for TAS is the group without hepatic metastasis. But we know that patients with just peritoneal disease are patients difficult to see the progression, and sometimes we lose the best time to treat. At this point, with the patient with just peritoneal disease, that you could see the best prognostic group for treating with TAS. Would you think about reintroduction before making a choice for TAS?
Okay, I like your three comments very much, because I see your people seeing a lot of patients. These comments come from people who see a lot of patients. I have challenged other audiences, and they came up with observations that didn't make very much sense to me. Okay, so I will get to your point. First point, if you ask what is the correct way of treating this condition, is reintroduction, okay? Because it is not a clear third line, as some of you have outlined. The second point is the one that Daniela made, and both of you agreed upon, that this is a benign course, and therefore I may shoot at quality of life, and therefore I may not choose the standard that would be reintroduction, because A, I don't need a shrinkage, and B, I shoot at quality of life. Perfect. Now you're posing a third issue. Actually, Andre posed an issue that I share very much, because in Italy, again, we are 95% public oncology. Okay, so we have reimbursement issues. So if these drugs were not reimbursed, well, you know, the benefit is quite marginal, I understand. When you're desperate, these benefits may seem substantial, though. I don't know what I would do without a reimbursement. I'm lucky to be reimbursed. I really felt bad when the checkpoint inhibitors were not reimbursed. Luckily, now they are. So again, you're posing a different issue. And that is, if that was a peritoneal progression, I would rank that condition among those needing shrinkage because of the reason that you explained. So I would go for a reintroduction if that was peritoneal. If that was, again, 2-3 small lesions in the liver and 3-4 1-2 centimeter lesion in the lung, oh, come on. I may choose Daniela and others' comments and say go for trifluridine. Okay, let's make one variation here. There. You see the difference? Daniela, what would you do in this condition? It's identical to the previous one, that is this one, but as you see now, you have a rapid progression.
Yeah, I think that's the case for reintroduction of oxaliplatin.
Exactly. I don't think we needed to discuss much about it, right? Also, what I failed to mention in my presentation was the response rate in the two trials, 2%. Now, there is an intriguing aspect about the response rates. Again, I remember those patients. Those were really terrible patients. Okay, now we have new data. Yeah, I think I can disclose them. Yeah, new data of first-line treatment with just trifluridine plus Bev. You know what the response rate has been? I don't know if that has been released in abstract form. It's a 38%. Wow. That means that because in clinical practice, I personally see more responses than 2% with trifluridine. That means that 2% is not reflective of the condition now, 10 years after the approval of these agents. Still, it's certainly in the single digits, the response rate. Whereas a re-challenge, a reintroduction here certainly will give me 30%.
May I ask you a question about the response rates? Do you think the high probability or the higher probability of response in your clinical practice is because some kind of selection of the patient, the right kind of patient you choose to offer the drug, or it's just a kind of number of patients treated?
No, actually, I think the opposite. I think that in the trial, we selected patients who were desperate. So a much worse patient population than what we see in clinical practice now. Actually, the pre-connect study, that was a real-world type of experience, had longer survival than reflecting this. Yeah, okay. Let's analyze this now. Now, this is first line, short-lived response, and then rapid progression. Second line, very favorable clinical course under FOLFIRI-BEV. And then maintenance, well-tolerated, average toxicity, maintenance, slow progression. How about this condition? Anna, your comment first. You see the point, how it is different. Say, before, you had a nice response lasting long. Now, we have a response that goes directly into progression at 5 months. Bad condition.
Yes, I think the first line wouldn't be the best option. The second line, you had a good time with maintenance, but the progression wasn't so important. So I would like to know the tumor burden here, and I think this seems that you could use something more with you don't need more response here. Right. So I think TAS would be an option here. Or I think you have here 8 months with maintenance. So one other strategy would be the second line again. I have the same problems as Sassi has in his practice. Sometimes we lose more time looking for the best treatment than doing different choices to go fast with our patients' treatment. Right.
Essentially, if you have a reimbursement problem here, you reintroduce FOLFIRI out of question. But without reimbursement problems, probably here, the best choice is again TAS 102. Any other comment?
No.
How about this guy? Who wants to comment? Now let's analyze it. So let's suppose this is a right-sided RAS mutated person, and initially he has some hint of efficacy from Zilox-BEV, rapid progression, no response to FOLFIRI aflibercept, say, that I would use in this condition because of the bad, you see the PFS is 6 months and not so good. And now you have a rapid progression. What would you do?
I think this is the worst situation for our patients, but I don't think any treatment could help this patient to prolong the survival. But sometimes we treat this patient with re-challenge with the first-line chemotherapy because of the response he had in the first line. But it's just a brief hope we have to make the patient present the some response again like the first line, but the probability I think is very low. But this patient will not benefit from any treatment. But I don't have any experience in this case with TAS or regorafenib, I think.
In general, any other comment? Because we do have experience. Daniela.
No, I think it's a bad scenario anyways. I think just like Andre, no comments.
Yeah, in these kind of meetings, we have colleagues presenting cases, and about a month ago, I saw a case exactly like this. Of course, this was a sponsored meeting by Servier. Okay, so you presented those cases where the drug is, how come that produced that fantastic result? Still, it's nice to see that there was that option. So because it is reimbursed, a case like this, we treat with trifluridine or regorafenib according to the rules I gave you, because it is reimbursed. I would not expect too much. In that case, a right-sided RAS mutated BRAF type, the patient is stabilized for longer than a year. So if I had to draw this line under TAS, this was the results. So again, but I agree with your comments. Let's look at this. Now there is a different player here, bad toxicity. And I think this shifts the picture more toward the use of single agents. Any comment on this?
I think
you have the possibility of double reintroduction, because never failed second line and never failed first line. Nevertheless, this qualifies for third line trials, because the eligibility criteria always cite A, progression, or intolerable treatment. That is why it is put down like that.
I think, Dr. Sabero, that in this case, as we have some data on earlier lines, first line with TAS as an example, we can discuss with the patient the better tolerability and the lower toxicity expected with the treatment. And now the patient could be more convinced to try some out-of-pocket payment. And this is, I think, the one situation that we can offer some control of disease, long-term control of disease, with a better quality of life, with the patient comparing the experience with the chemotherapy previous made. So the quality of life is more tangible, more predictable, as a strong benefit for him. So I think we can, in this case, discuss with more property and with the clinical practice, and expect some benefit in long term. I think is the better case for TAS as an example. But in a clinical practice, here in Brazil, we reduce the dose of chemotherapy, lower dose, and try to maintain maintain the chemotherapy tradition.
Okay, okay. Any more comment, because we have come to the end of our hour and we want to finish on time. Any more comment on these cases?
No, thank you.
Dr. Sobrero, in interesting cases, we had the possibility to know more about cancer, colorectal cancer sequencing. Thank you very much to be with us, to accept our invite. We expect to have more moments like this with you. Thank you for Servier for making the invitation for Dr. Sobrero. Thank you for our colleagues, André Sassi and Daniela Pezzuti, for the moderation. And thank you, everyone. We are expecting you for the next scientific meetings.
Okay, thanks very much and congratulations. I share a lot of your comments. Absolutely. Thanks very much. I really enjoyed it. Bye-bye.
Thank you. Bye-bye.
Thank you very much.